Welcome to today's Grand Rounds special presentation. This is a panel presentation. I am both presenter and host, along with Carrie Cochran-McClain and Josh Jorgensen from the National Rural Health Association. They will each introduce themselves as each of us first tells our story of how it is that we became involved in advocacy and what it is about advocating for rural health that may be a bit different than advocating for other issues. So my story, I wrote an essay one time, which I entitled "To the Hill and Back." And it was written after a particularly exhilarating experience up on the Hill during the Policy Institute, the National Health Association Policy Institute, followed by some very disappointing news that I received in the airport on my way back home. But it illustrates a little bit my journey as an advocate for rural health. My experience in advocating for rural health really started growing up, but even more so in early practice as a rural physician in West Central Ohio. And a lot of my advocacy efforts in the beginning were directed toward concerns at the patient and community level. I was very much a local advocate. I would advocate for an individual patient before a specialist, or I would advocate for a group within our community to get some kind of accommodation by our local hospital. For example, the Amish had difficulty accessing our hospital because of the expense and because of a generally unwelcoming atmosphere among the staff, and worked over the years to help change that. I wasn't really engaged with on the national scene, nor did I understand how important my engagement was until 2003, when I started a program for medical students from Ohio State University to come to a cabin in the woods and spend some time focused on some topic in rural health. And the first Rural Health Scholars Retreat, we invited Steve Wilhide, who at that time was the president of the National Rural Health Association. As part of the program that I had designed, we chose two of the scholars to go with me to the Policy Institute and make a trip to the Hill. And that fellow sitting in front of the fireplace there in the green was one of our first two rural scholars. Since that time, I have gone to Washington every year, and here's the picture from 2019. 2019 was an important year for me because there were some things starting to move in rural medical education, and having a student interested in general surgery and another student interested in rural family medicine practice, and one of our faculty who one of these days I'm sure is going to run for Congress. It was a really interesting experience. Dawn Malika is the administrative director of our office, and she and I every year take several students. The students we took in 2003 formed the nucleus of a group that eventually resulted in the student constituency group at the National Rural Health Association. And now every year we have students attending our rural medical educators meeting in the day before the annual conference for the National Rural Health Association. I've been a part of the Ohio contingent every year when we go to the Policy Institute. And Mr. Wilhide was really my mentor and coach in the early going because he went with us the first 2 years. And then as time went on, I became the most senior member of the group generally. And the students and a few of us were the only people from the whole state of Ohio who would attend this institute. And so it was very much, our efforts were very much focused toward rural medical education. Every year we made contact with our members of Congress, and over time have developed some relationships, which is really important. Last year, my congressman's aide connected me with Casey Quinn and Brad Wenstrup's office. He's from Cincinnati, Ohio. And although we had no students with us that year, Casey was very interested in the work that he was doing as co-chair of the House Ways and Means Task Force on Rural and Underserved Health. We met with them again this year, and it was amazing. I had given her information last year about some of our concerns around rural medical education, and in December suddenly got an email from a staffer for the House Ways and Means Committee who asked me to provide some really detailed information about rural medical education, rural residencies in particular. And I wasn't sure what they were going to do with that information. But imagine my surprise when the Consolidated Appropriations Act of 2021 was signed by President Trump just a few days before Christmas. And I came to find out it had 3 GME provisions in it that I've been advocating for 20 years. And finally was seeing some movement. It was a really gratifying experience, and getting the backstory from Casey as to how that all came down was really, really interesting to me. So persistence pays off. And I would just say that I discovered that sustained relationships with your members of Congress as a credible source of information is really important. And even more important, relationships with the staff. Although some staff turnover, there are others who have persisted over the years. Keep your message simple, keep it the same, and be ready when the time comes to provide the information they need, and expect things to maybe move more quickly. There were so many others involved in that story I just told that were working behind the scenes on the same issues I was concerned about. And it was really a matter of everything coming together and lining up. It really does take a team. And I learned that advocacy is less about persuading minds and more about establishing trust as a credible and responsive source of information. With that, I'll turn it over to Carrie and Josh.
So this is the team at NRHA that works on government affairs, Josh and I, and then we have a fabulous colleague named Mason, who is a North Carolinian native and came to us out of UNC Chapel Hill. I think not to assume that you guys know what the National Rural Health Association is, if I could just take a minute on that. So we are a national nonprofit member organization. We have over 21,000 members made up of kind of anyone who cares about rural health. So a lot of providers, as you can imagine, a lot of hospitals, physicians, rural health clinics. We have a lot of researchers and academics. We've got kind of community-based organizations. We've got kind of across the gamut. And the common goal is really to make sure that rural communities have access to quality, affordable care. And we focus on programs, policy, and kind of research in order to do that. So next slide. And I know that a lot of you, it sounds like, are pretty well versed already in rural health and some of the challenges facing rural areas. But we know that there are about 60 million people living in rural areas. So that's about 20% of the population over a huge percentage of the land mass, if you looked at it on a map. And like we started the conversation, there are a lot of kind of unique features or unique challenges to the rural parts of our countries. So, there are things like, and people use this adage, and I'm going to find a different one, a different way to phrase this, but the older, sicker, and poorer adage. So we know that 60-some% of older adults, meaning people who are over the age of 65, live in rural areas. So it's by far kind of an older population. There are higher rates of chronic illness. We know that people living in rural areas are more likely than their urban counterparts to die of the 5 leading causes of death. So there's a big disparity there. We know that there's lower access to critical services like primary care, like mental health and behavioral health services that we've talked about already. We also know that taking that context and then layering COVID-19 on that has meant a really challenging situation for rural communities. And while the incident rates of COVID between rural and urban are now pretty equal, the mortality rates in rural areas far outnumber the urban. So we know that the impact that COVID is having in rural is surpassing its urban and suburban counterparts. We've got issues like maternal mortality that you all sound like you're very aware of that are unique in being able to get people access to care, to specialty services that are critical to their health. We also know that we have a lot of workforce shortages and challenges. Over 3/4 of rural counties in this country are HRSAs, or health professional shortage areas. And that holds true. I think the numbers are actually higher for the dental and mental health HRSAs. And we also know that the safety net that we are working within in rural communities is more vulnerable. So we've got higher rates of poverty among rural Americans, and especially around rural children, where 1/4 of rural children are living in poverty. And then we've got the infrastructure that's supporting them is more it can be more vulnerable. So we've had 135 rural hospitals closed since 2010. So even kind of the backbone of care in rural communities has some unique features to it due to payment methodologies and workforce shortages and other things. So not to be too negative, if you turn to the next slide, we also know that there are some really wonderful things about rural areas. And that ranges everything from, in my opinion, the quality of life that you can have in those areas. From a provider perspective, we hear a lot about the connection to patients and the high rates of patient satisfaction and that relationship. Rural areas have higher sense of community. There's very much of a can do and take care of your neighbors kind of mentality to it. And rural areas are really, really diverse, even though I think a lot of times we think of them as being kind of a homogenous kind of farm community. That's absolutely not the case. And so there's a lot of richness in our rural areas and rural communities to learn from. So next slide. If you think about kind of what we at NRHA are fighting for as we work on Capitol Hill and with the new administration, we have our efforts kind of focused in 3 primary areas. So the first is around addressing declining life expectancy and inequality among rural residents. So getting at those issues of health disparities, getting at the fact that rural folks have a declining and shorter life expectancy compared to the urban counterparts, and that was pre-COVID. So I mean, at this point, it's much exacerbated. So there's a lot that fits in that bucket. Everything from kind of social determinants of health and kind of race, income, geographic disparities and access challenges. Lots we can dig into there. The second bucket is around rural health workforce shortages, and we talked a little bit about that already, but how do we use our policy levers, everything from kind of the beginning of the pipeline in getting individuals interested in healthcare professions, going all the way through kind of the training programs, the residencies, getting those in rural areas, all the great GME work that Dr. Longnecker, has done. It's thinking about what are those incentives and how do we get people trained and then distributed in rural communities. And then last is looking at the rural health safety net. And that's, I think, where the question of being able to have the institutions like rural hospitals in our communities, both as important economic drivers for the communities, but obviously important access points, and making sure that we can stabilize those facilities in the short term and then really spend some time thinking about, in the long term, what are the models of care that are right in our rural communities, and knowing that one size isn't going to fit all. So how do we create a number of different provider types recognized by payers so that we can help communities do a needs assessment of what's the right kind of mix in their setting, and make sure people have the access they need. So that was a lot. I can go and I can keep going, but I'm gonna turn to Josh now, and he's gonna talk a little bit about how we take all of that richness of what we want to do and think about what are the tools to make that policy change and influence policy at the federal level. So Josh.
Yeah, thanks, Carrie. So like Carrie said, we take, largely that message, put it into different asks, pieces of legislation. We find legislation that aligns with, those outcomes. And then we go to Capitol Hill and we try to advocate, and we encourage you all to do the same. So, I think the most important question is, what is advocacy? Because you see it on, TV and in the movies. It's likely a really contentious meeting where it's, high stakes. And that's not really how it needs to be. I think the most effective way to advocate is really to use it as an opportunity to educate, your member of Congress or your senator. You think about who these folks are. Oftentimes, if one of us ran for Congress, we'd have a good idea as to what healthcare is and outcomes that we'd like to see. But for me personally, I wouldn't know much about the business world or stock market. So everybody comes to being a member of Congress or a senator from a different angle and from a different, life challenge and different life goals. So, having that idea in the back of the brain is good, because it helps you educate and know and teach them where, we need to advocate and where we need to see greater outcomes for healthcare. And so it's really just the tool to educate and then let them take it from there. So you tell them what the issue is, why it's important to you, why it's important to your community, and then they'll move on to the next level. Next slide, please. And so why should you in particular advocate? I think what me and Carrie share all the time is that you care most about your community, your community, and you understand what is needed within your sector. Not only that, but you have knowledge and experience that members of Congress and their staff want and need. When I worked on Capitol Hill, hearing from folks like Carrie and I who are based in Washington is great, because you get really good background on the issue and you understand some of the data and statistics. But it's really important to hear how it actually impacts a provider in your community, individuals and employers in the community, because that's what they need to know is, if I, sign X into law, it does Y in my community. And that's the most important thing. And what my former boss always used to say to folks was, if you don't advocate, somebody else will. And not always will you agree with what they're advocating. So you need to get out and put your stories out there and let, folks who are making important decisions know how it's really going to impact real world folks in their own communities. Next slide, please. Thanks. Just a few tips quickly on how to frame message. I think the most important thing is explain your position, both problems and solutions, in really lay terms. Kind of like I said, not all staff members or elected official may come to it from a healthcare background. So, bringing it back to kind of the basic level is the most important. And then identify 2 to 3 critical points in your case. And most importantly, it's important to use data, especially tied to their district or state, to make your point. I always think it's really important that if it doesn't directly impact you, don't make up a story as to how it's going to do so. Just share, the community down the road is having this issue, and it's important because this could happen to us in the future, or whatever the case may be. And then along those same lines, always remember to be truthful, and your credibility is really the most important asset you have. I know coming from a rural community or rural state, I use, they say the 6 degrees of Kevin Bacon in film, it's like 2 degrees in rural America, right? Like I know a lot of folks who would come and advocate on Capitol Hill from South Dakota, and you likely would know some of their family members or whatever the case would be. And so creating that relationship, it helps the staffer and you want to reach out and talk about those issues, not even on the specified time frame of once a year. So it's really important to create those relationships. And next slide, please. Lastly, we just have 5 quick tips to remember when advocating. Number 1 is have a specific ask, co-sponsor S1, 2, 3, 4, support this bill, vote against this bill, whatever the case may be. Number 2, talk to a decision maker. Really try your best to reach out to the office and find out who their health LA is. Don't just send it to the, sometimes unmonitored email box. Try your best to find out who the decision maker in the office is and reach out to them. Number 3 is know who you're advocating and do your research. Like I said, not everybody's on committees of jurisdiction. So if they're not in the Senate on, the Finance Committee or the Health, Education, Labor, and Pensions Committee, they might not be intimately familiar with the piece of legislation that you're talking about. So that means you'd want to step back and do more explaining. Now, if they are on committee, you can likely move forward, assuming that they might have some knowledge of that issue. Number 4 is explain why it's important to you and other constituents. That's arguably the most important. And then lastly is be concise and make sure to follow up. If you tell them you're going to send something over to them, try to do so in a responsible time frame. You don't need to rush out of the thing and get on your computer and send it within 20 minutes, but just be sure to follow up and provide answers to the questions that they have. And lastly is how can you help advocate for rural health? Just quickly, NRHA does a lot of advocacy where we have pre-written emails and letters drafted by our team that you can send to your members of Congress and the administration, and we can share those with you all after the call, but that's based off where your zip code is. So if you just put your name and email in and your zip code, it'll go directly to your community. Attend local town halls virtually right now, of course, but try your best to speak with your members of Congress and understand what they're working on, what's important to them, and how you can craft where they're coming from into what policies you would like to see created on the back end. And then we have a few tools, the NRHA Rural Roundup and NRHA Today, that kind of keeps in touch with what we're working on with rural health. And then lastly, we do have social media, Twitter, Facebook, LinkedIn, that y'all can follow. And then Carrie and I's email is located down there at the bottom.